good morning, and thank you for asking me to speak on what was a very interesting, animated debate that we had this morning on the value of arthroscopic stabilization as a revision procedure for people who failed previous stabilizations. We're at the Emerging Techniques in Orthopedics meeting, which the American Journal of Orthopedics has been intimately involved in delivering, and it's been a wonderful meeting. I had a debate this morning with Dr. Robert Burks, who is a wonderful didactic professor. My name is Brian Cole. I'm at Rush University Medical Center in Chicago, and I have an interest in sports medicine. About half my practice is shoulder, and I have a specific interest in shoulder instability. So the debate this morning really focused on arthroscopic versus open, and I think the major take-home is that, at least in my opinion, and maybe if you get Dr. Burks to speak, he may have a little bit of a different slant, but the take-home for those of you who perform arthroscopic procedures for individuals who have instability is that the bottom line is our goals are the same. We're really trying to achieve a stable shoulder, and it probably doesn't matter whether it's done arthroscopic or open. It's what you feel comfortable with. So the major emphasis is assuring that you get the job done and get it done right. So if a person fails, for example, a previous arthroscopic procedure, if there's pathology that was missed, for example, or there's new pathology, most commonly, except for maybe bone loss, almost everything can still be managed in arthroscopic fashion. There's really nothing unique about doing a procedure open that it creates a more likely outcome that's associated with less recurrence. Some have argued, for example, there's more scar tissue formation and so forth, but I would argue that's actually a potential downside. There are several wonderful arthroscopists, Pasquale Below, for example, who has taught us that we can even manage bone loss arthroscopically. Most of us, though, will be challenged in that particular environment. So the real issue is, why does a person fail, and can you correct the reasons for failure arthroscopically, and if not, do it open? And the most common reasons for failure are a recurrent Bankart lesion and or insufficient capsular management the first time around. And one of the things that I've learned is that I most commonly now will address the posterior inferior quadrant, whereas in years past I would often ignore that and just treat the Bankart lesion. I think there are subtle contributors to residual instability that we're not able to address in totality by an anterior-inferior repair. So my basic approach now is that I will always put essentially 3 anchors, and 2 of them are anterior-inferior and 1 of them is posterior-inferior through a 7 o'clock portal. Now, I trained on the East Coast and learned beach chair position, but I really can't do instability, reconstruction, or repair in the beach chair position adequately. I think if those of you who do lateral decubitus understand that to get access, you really need traction and abduction force. And you can drive around, pretty much get access circumferentially and fix virtually anything with current instrumentation. So the 7 o'clock portal is a critical portal to establish posterior inferiorly, and through that portal you can address the entire posterior compartment of the glenohumeral joint. And it's hard to do in a beach chair position, but much easier to do in a lateral decubitus. The remaining pathology that I think is tough is when there's glenoid bone loss. Humeral bone loss, relevant Hill-Sachs lesions, especially in a setting where there's minor degrees of glenoid bone loss or attrition. Remplissage procedure, as popularized by Eugene Wolfe, is a procedure that is basically almost a tenodesis of the infraspinatus into the Hill-Sachs lesion, and that basically renders that portion of the humeral head extra-articular. So even if an individual has translation, they can't translate into the defect posterior superiorly. That's a wonderful bailout in a setting where you just don't want to go the whole way in terms of fixing the anterior glenoid. That being said, one of the most reliable procedures to date is a coracoid transfer, Latarjet or Bristow, that reconstructs the anterior glenoid, and I think we can't be afraid to do that operation, especially in a high-risk athlete, especially in a failure situation where there's, say, 15 to 25% bone loss. But it's not the absolute percentage, it's really the whole clinical picture taken in the context of the nature of the athlete, the risks they're exposed to, and then all the coexisting pathology that's identified at the time of arthroscopy and the exam under anesthesia. So pay attention to detail. And I think your patients will benefit from it. Understand the pathoanatomy, and don't leave any stone unturned. And I think the likelihood of failure, whether it's done arthroscopic or open, will be extraordinarily low in your practice. Thank you.